Thank you, Ahmed Touair. Again, I'd just like to thank the Kenyan Renal Association for inviting me to attend the conference. It's been excellent talks all day, and I've thoroughly enjoyed it thus far. So I'll start off by saying that hypernatremia is generally regarded as a sodium concentration of more than 145 millimoles per liter. And very importantly, whenever you are confronted with a patient who has hypernatremia, you need to keep in mind that there is a problem with the water control mechanisms within the patient. And I'll show you something on the next slide. I'm going to show you some local South African data from our side that Prof. Yazied Davids recently published in the African Journal of Nephrology. And then I'm going to compare to some international data published by Paul Palevsky in the United States. And I will finish off again with an interesting case, courtesy of Professor Yazied Davids. So just to remind you about the control mechanisms for water in the body, there is the osmostat, which is located in the hypothalamus. And when the osmolality increases, and in particular the sodium above 140, two things are stimulated. The thirst center, which we tend to forget about, but very important in maintaining osmolality. And then, of course, the vasopressin release from the posterior pituitary gland, which then binds to the kidney and causes water retention. Now, in patients with hypernatremia, there can be issues with the osmostat, the links with the thirst center or the thirst center themselves, or issues with vasopressin release or enzymes that actually metabolize vasopressin, so-called vasopressinase, classically seen in pregnancy, and of course, nephrogenic diabetes insipidus with kidney disease. Now, here is the paper that I alluded to earlier, the paper published by Ali Abu Hajar and Professor Yazied Davids, and I'm just going to show you some of the interesting findings out of this paper. So they looked at hypernatremia over a 3-month period at our hospital, Tygerberg, and they defined hypernatremia as a sodium concentration of more than 150 millimoles per liter. And as you can see here, there were just over 13,000 admissions during that time period, and they actually found a total of 204 episodes of hypernatremia, giving a prevalence of 1.5%. Now, over that 3-month period, it was interesting that most of the patients that had hypernatremia actually developed hypernatremia during hospitalization, with only a third of the admissions actually having hypernatremia at the time of admission. So it seems that hypernatremia is mainly a condition that develops in hospitalized patients. And I will get to the causes later. So these were the proportions of patients that were admitted with hypernatremia and the wards that they were located in. And as you can see here, most of the patients were actually in medical or surgical wards, with less patients in the ICUs. And the authors postulated that our hospital have relatively small numbers of beds for patients in the ICU. So many critically ill patients end up in normal medical wards or surgical wards and require therapy simply because there's no beds available for patients in the ICU. This is an interesting slide showing the timing of the hypernatremia. So the blue represents patients that had hypernatremia at the time of hospital admission, and the orange, the patients that developed this during hospitalization. And as you can see, interesting, most of the patients that developed hypernatremia, the more patients developed this in the ICU, surgical or medical, rather than in the wards. And these were the primary contributory factors that led to hypernatremia. And you can see dehydration and hypovolemia was nearly present in half of patients. Sepsis was a very common cause in conjunction with kidney failure. Those three seem to be the main primary conditions contributing to hypernatremia. And I just want to point out to you here, diuretics represented roughly 20% of patients, a contributory factor. And these conditions were not mutually exclusive. Many of them occurred, one or two or three risk factors were present in the same patient. So a handy tool that one can use, particularly in critically ill patients in ICU or in high care areas, is the so-called tonicity balance. And this is really monitoring the fluid that goes into the patient, whether it be normal saline, because we know the concentrations of sodium within each solution, as well as the volumes that are given to patients in hospital. And then we monitor the outputs. And on urine samples, we can actually send away, as you know, we can test the sodium concentration in every lead, and the concentrations will be reported as millimoles per liter. And therefore, we will be able to determine whether the hypernatremia was either due to salt gain, i.e. too much sodium coming in and very little leaving the patient, or water loss. Either, so in other words, the patient is he has a high urine output or is not getting in enough water, or both. So this is what we regard as the tonicity balance. Very important here to point out that even if you don't have the type of fluids that were administered to the patient, and you don't know what the sodium concentration is in the urine, as long as you have the volumes of fluid that went in and the volumes of fluid that were excreted, you can still determine what the mechanism for the hypernatremia was. If water in and water out is the same, then it has to be a sodium gain issue. So this was the fluid balance for patients in ICU. And as you can see here, in just over 80% of patients, the mechanism for hypernatremia in these patients was sodium gain. This was the difference between the patients that had hypernatremia on admission versus those that developed it during hospitalization. And the only difference was the duration of hospital stay. For some reason, patients that had hypernatremia on admission had shorter length of hospital stay and nearly double the amount of time in patients that developed it during hospitalization. Interestingly, there were no differences in the age, the time to normalization, or the mortality rates between the two groups. And in fact, the sodium concentration peaks were also pretty similar. And this was the overall mortality for patients during that 3-month period that had sodium concentrations above 150 millimoles per liter. The overall mortality was 38.7%, and this is pretty similar to other reported studies reporting on hypernatremia mortality. But the interesting finding here is that as the sodium concentration rose, the mortality, in fact, increased exponentially. The only reason for the lower numbers in the above 165 millimole group is simply because there were less patients above that had sodium concentrations above 165. So on multiple logistic regression, predictors of in-hospital mortality were age and the peak sodium concentration. So the older you were and the higher your sodium concentration was, the more likely you were to die. So I'll now move over to an international study that was published quite some time ago in 1996. But the reason I chose this study is because the definition for hypernatremia was the same as the one in the study done by Abu Hajab et al. And they also looked at hypernatremia over a 3-month period. So they also used 150 millimoles and over a 3-month period. And interestingly, they specifically mentioned that patients who came in with hypernatremia on admission were in fact much older relative to patients that developed hypernatremia during hospitalization. And in fact, the paper mentions that hypernatremia on admission seems to be a geriatric disease. The sodium concentrations were also slightly higher in patients admitted to hospital. And of course, the patients, unlike the study, the South African study that I showed, you can see here that the time before hypernatremia was 25 days rather than 13 days, as mentioned in the South African study. The patients that developed hypernatremia during hospitalization mirrored those of the general hospital population. So they looked at urine volumes in patients that had hypernatremia on admission versus those that developed hypernatremia during hospitalization. And if we use a cutoff of 3 liters as polyuria, you can see here that patients that had hypernatremia during admission did not actually have any polyuria, whereas just over half, just under half of the patients that developed hypernatremia during hospitalization actually had polyuria as well. And when we look at the urine osmolalities between the two groups, in this study, they defined a good concentrating ability if the urine osmolality was 700 or greater, and they diagnosed diabetes insipidus if the urine osmolality was below 300. And as you can see here, patients that admitted to hospital who had hypernatremia at the time of hospitalization actually had excellent concentrating ability. But the patients that developed hypernatremia during hospitalization, in fact, some of them actually had, by their definition, diabetes insipidus, but as you can see, poor renal concentrating ability. So what were the contributing factors to this poor concentrating ability in the hospitalized group that developed hypernatremia during hospitalization? And the main reasons, as you can see here, was diuretic use in just over half of patients, and then osmotic diuresis due to either glucose, urea, or mannitol use, and of course, renal insufficiency played a role in both groups. So there seemed to be a renal concentrating defect issue with hospitalized patients, and it seemed to be driven by diuretics as well as osmotic diuresis related to organic osmols, such as glycosuria, poorly controlled diabetes, essentially. This was the fluid administration and enteral feeds given to these patients during hospitalization. And you can see here, this was the fluid administration immediately before the onset of hypernatremia in the hospital-acquired group. So about a third of patients, just under 30% of patients, actually received no enteral feeds. And another 45% of patients received less than 1 liter of fluid a day. And then of the 70% of patients that actually got some form of IV fluids, 40% of them actually received the IV fluids in the form of normal saline, and another 10% of patients actually received hypertonic fluids. So it looks like in this group of patients in this study that hospital-acquired hypernatremia seems to be inadequate intake of fluid via the oral route, inadequate fluid administration in terms of small volumes, and when patients were receiving fluids, IV fluids, it was inappropriate solution selection, i.e. normal saline, rather than electrolyte-free water such as dextrose or half normal saline. And the mortality rate was pretty similar to the South African study. You can see here 41%. And there was, although the mortality was lower in the patients who developed who came in with hypernatremia, there was no statistically significant difference between the two groups. Interestingly, the authors also mentioned that the cause of mortality was not related to the hypernatremia. And in fact, they went through all the medical records of all the patients that died and could only ascribe the mortality to 16% of the patients due to hypernatremia. In other words, the vast majority of patients that died from the primary reason they were admitted rather than the hypernatremia. So I'm just going to move on to the case that I got from Professor Yazied, and it's a very interesting case of a patient that developed polyuria after neurosurgery. And it was a patient that had a berry aneurysm clip successfully, but immediately post-operatively had a urine output of 600 moles per hour. And as we can see here, the patient's sodium concentration prior to surgery was completely normal. And post-operatively, this was the plasma sodium concentration of 156. And one can also see the urine sodium of 37 with an osmolality of 120. So on first look, it looks as if this patient has diabetes insipidus. It looks as if this patient's urine, osmolality is inappropriately low, and it should be concentrated in the context of hypernatremia. So it does look like diabetes insipidus. So the question really that you need to ask yourself is, if this is diabetes insipidus, is this a water loss issue, or has the patient gained sodium? And again, this is where the tonicity balance comes in very handy. And when we looked at the charts of the anesthetist for the fluid administration and the urine outputs, we could see that the patient received 5 liters of normal saline, but excreted 5 liters of urine. So just on looking at the urine output, it doesn't seem to be a water loss issue. It therefore has to be a sodium gain issue. And in each liter of normal saline, the patient received roughly 700 millimoles of sodium for every liter, with 5 liters of saline, and excreted 250 millimoles of that was administered. And therefore, the patient gained 500 millimoles of sodium. So how does one get rid of 500 millimoles of sodium? Or as the clinician, we can either tweak what's going into the patient, and we can tweak what's coming out. And that's exactly what we did in this case. We tweaked we switched the patient from normal saline to half normal saline, as you can see here. And we gave the patient Lasix in order to force sodium out of the patient. And the urine, and as you can see, the sodium concentration rose from 35 millimoles to 175 millimoles with Lasix. And therefore, for every liter of half normal saline administered, the patient went into a negative balance of 100 millimoles of sodium. So the message here really is, in hospitalized patients where you can monitor the intake and the output, a tonicity balance is really very handy. It cannot be used in general medical wards where monitoring of the fluids administered and the excretion of urine output is poor. So you have to use it in an ICU setting or in a critical care setting. And as was demonstrated in this case, if it's not water loss, it has to be sodium gain. So in summary, some of the take-home messages from this study, from my presentation, is that Hypernatremia at admission is almost always a water loss issue. So it's usually patients that are not taking in well, that have diarrhea, and as a consequence develop hypernatremia due to water loss. Whereas in hospitalized patients, the mechanism for the hypernatremia is almost always sodium gain. And this this is particularly common in the ICU setting. So in the ICU, it is very uncommon for the ICU, for our ICU colleagues to withhold fluids to patients in the ICU. They tend to give more fluids rather than less fluids, and make use of the tonicity balance, even if you don't know what the sodium concentration is in the urine and you don't know the types of fluid administered. If you know the volume of fluid that went in and you know the volume of urine excreted, you can actually determine very quickly whether it is a water loss issue or whether it is a sodium gain issue. And mortality is very high and is not related to the hypernatremia, but rather related to the primary cause for hospitalization. Thank you.
Talk. Maybe can ask one or two questions. One of the challenges we have is, what fluid do we use in hypernatremia? Should we use half-strength normal saline, or should we use 5% dextrose?
Interesting question. So, Ahmed, as I've mentioned earlier, you really need to know what is happening with the urine sodium concentration in the urine. So we've had previous cases where a patient was given normal saline, developed hypernatremia, the sodium went from 140 to 150. The treating clinicians then decided to switch to half normal saline, and the following day, the sodium was 160, despite using half normal saline. And when we actually checked out the urine sodium concentration, it was 35 millimoles per liter. So in other words, half normal saline has 75 millimoles of sodium per liter. And for every liter of urine that this patient was making, he was only excreting 35 millimoles. So in other words, he was retaining 40 millimoles of the 75 millimoles. So what we did was we actually switched the patient to dextrose and gave the patient nasogastric tube electrolyte-free water, tap water, and we gave the patient Lasix in order to increase the sodium excretion in the urine. And that actually caused the sodium concentration to come down. So I think a very important thing, before deciding which fluids to give, send away a urine sample to find out what the actual concentration of sodium is in the urine.
Okay, thank you very much. Another very interesting question is, what drives the thirst center? Is it the coolness of the water? Is it the volume of the water? Or is it whether it's still water or sparkling water? Because this is a practical, everyday life type of question. You feel thirsty, you want to drink water. Which is the best way to quench your thirst? To drink a lot of water, to drink cold water, or to drink sparkling water?
Okay, so I drink lots of sparkling water, but that is just my preference. I don't think it has anything to do with the temperature of the water or whether it is sparkling water. It has to do with lowering the serum osmolality. So regardless of the temperature of the water, if your sodium concentration is high, and the osmostat in the brain is very sensitive to small changes in serum osmolality. So in fact, if your serum osmolality goes 2 millimoles above 140 millimoles per liter, it is a potent stimulus for you to actually consume some water, whether it is warm water or cold water. And for patients to get to sodiums of 150, 160, it is because they either intubated and can't stand up to go to the tap, because they're not being given the right fluids, or they have delirium and can't actually respond normally like a normal person would to the hyperosmolality. So just in summary, it's not the temperature or the gas or the coolness of the water, but just drinking water, which is important.